the last speaker of our day, Dr. Yu, who is the principal investigator of the U Lab at Boston Children's Hospital. I know you made national headlines with some of your really transformative, individualized treatments. It's really a pleasure to have you here today to tell us more about your research into individualized molecular treatments. Dr. Yu?
Thank you so much, Sabrina. Can you hear me okay?
Yes.
Good. It's a real honor to be asked to participate in this ALS ONE symposium. First, just to get the chance to follow colleagues and mentors and that I've admired for a long time and gotten to work with. It's directly in the session, of course, with John, Neil, Bob, and Jerry. And of course, Merit to open the day. But as I was thinking about my participation in this symposium, I was also reflecting on the fact that I am a neurologist at Boston Children's Hospital. And when I thought about what field I wanted to work on to try to devote my research efforts when I finished residency in 2007, I really looked at ALS as a model. I looked at ALS and also spinal muscular atrophy, as Jerry's remarkable work also demonstrates, as a model for a place that neurology had to get to for more diseases. ALS, spinal muscular atrophy, these are conditions for which we had made really critical advances in the genetics underlying these conditions, understanding the molecular mechanisms underpinning these diseases. And then we're beginning to think about therapies. And those investments beginning in 2007 have had this incredible payoff. Not beginning in 2007, but as I was reflecting on thinking about.
And Dr. Yu, I'm sorry if I interrupt you. Are you trying to share your screen, or
I will in a
you're
moment.
not? Okay, perfect. That's wonderful. Thank you.
I just had a couple of just wanted to share some of these opening thoughts. As I thought about where I wanted to work, I knew I wanted to work initially in trying to create more ALS and SMA-like opportunities for neurology. And I went back to a field that was probably perhaps 15 years behind where ALS and SMA were at the time in pediatric neurology and pediatric neurogenetics, trying to understand the genetic basis for many neurodevelopmental and severe neurodegenerative conditions that occur in kids. But back then we were just starting with understanding the genetic causes, not yet ready to begin thinking about treatments. So with that long-winded intro, let me go ahead and open up my slides. And I will share with you some work that's been going on in a sort of a parallel track to the remarkable work that's happening for ALS. And this is work that's happening in the space of orphan pediatric neurogenetic disorders that are some as rare as some types of ALS and others much more rare than most ALS. And I thought I don't have as in-depth of an elegant story to tell you about any one of these cases, but I thought I'd try to give an overview of this interesting parallel track that has evolved hand in hand, side by side with the remarkable advances in ALS. And this work and this overview I've titled Individualized Investigational Therapeutics for Neurogenetic Diseases. Here are my disclosures. And again, from a personal perspective, working in pediatric neurodevelopmental diseases is where I got started in 2007. And our mission then was relatively simple and straightforward, which was to try to understand what the genetic basis for these conditions was. And we were lucky to start this work at the time when next generation sequencing was just becoming available. And it was an incredibly productive 10, 15 years where we were able to apply these fantastically impressive new tools to hugely shorten the odyssey for gene discovery and for gene diagnosis. And as this satisfying work was ongoing, we reflected on the fact that there were still treatments, the path to treatment remained very long, and the available treatments for these conditions, even as we were discovering dozens of genes for epilepsies, for neurodevelopmental disorders, learning disabilities, autism, and other conditions, that our understanding of them and a therapeutic approach to them seemed really pretty distant. That's this cartoon here that I sometimes reflected on as I was thinking about the progress we'd made and how far yet we had to go. We were doing a wonderful job uncovering all of these hundreds of new neurologic genes, but not yet sure what to do with them. Interestingly, though, our group in the last 5 years has found ourselves really benefiting from the genetic therapeutics revolution, as well set up by John earlier in this session, by Jerry's talk and others. There are increasing ways of intervening genetically for disease mechanisms that we understood. And our window into this space really began unusually with not a scientific inquiry, but actually a social media post. Our window into this space began in January 2017 when we happened across a Facebook post posted on the Physician Moms Group of Massachusetts, describing a plea for help. This quoted from this post: "I'm hoping the power of this Facebook group can help my dear friend. Julie and I were college best friends. Her 6-year-old daughter had just been diagnosed with Batten disease, a neurodegenerative disorder. There is no cure. Their doctors are recommending whole genome sequencing. If anyone can help in any way, Mila's family would appreciate it so very much." And that unusual introduction launched us into a gene diagnosis odyssey for this family. We did whole genome sequencing for this family who had been diagnosed with Batten disease, a rare and orphan condition, and found that she had an unusual mutation that disrupted gene splicing. The normal, she had genetic pathogenic variants in the CLN7 gene. The normal version of the gene is shown on top. It encodes 13 different exons. And one of her copies of the CLN7 gene we discovered via whole genome sequencing had a misplaced segment of genetic code, a retrotransposon insertion. And this was a deep intronic mutation in between exon 6 and 7, and it was creating a new splice site. It was this recognition that there was a unusual non-coding mutation causing her condition that got us reading about antisense oligonucleotides, as have been abundantly now covered in this symposium. And back in 2017, I think there were many people who knew extensively about ASO work and had been worked on these for decades, but clinically, they were just launching into our clinical consciousness because of the remarkable work of Ionis and many investigators working together with that company to develop Spinraza for spinal muscular atrophy. As you've already heard, these are short snippets of synthetic nucleic acids that can be manufactured very simply. They can be used to modify splicing patterns. They can be used to knock down genes if there's a toxic gain-of-function mechanism of action. And because they're modular, they're easily customizable to different genetic targets. Again, I'm going over things that have already been covered nicely by John at the beginning of the afternoon. And it was our rapid education in antisense oligonucleotides, talking to people like Frank Bennett, also the president of the Oligotherapeutics Society, Art Krieg, and many, many others, that emboldened us to try to harness this technology in a novel way. We decided to try to design an antisense oligonucleotide that was tailored to our patient's specific mutation, a unique mutation found only in her. She was the only patient in the world with this mutation and remains the only patient in the world that we found that has this mutation. And the goal of our tailoring an ASO to her mutation was to try to suppress the use of this abnormal splice site that had been created by the mutation. And that led us to develop, to our surprise, actually surprisingly quickly, some potent-looking lead candidate molecules that, when tested in our patient cells and patient fibroblasts, could restore normal patterns of gene splicing simply by sterically hindering access to the splice site created in her deep in between exon 6 and 7. And we were able to furthermore show that restoring normal patterns of gene splicing allowed us to improve cell health, culturing her fibroblasts, showing that they had severe lysosomal defects, as illustrated by these electron microscope images, showing that there were abnormal white storage vacuoles in the cytoplasm of her cells. We saw that those storage vacuoles melted away when we treated them with our lead oligonucleotide, really suggesting that the RNA improvement was also being mirrored by cell biological improvements too. And in thinking about this antisense oligonucleotide technology and the various clinical advantages that have been covered in the symposium, how easy they are to manufacture, and how well biodistributed they are, and how successful they had been in nusinersen, which was just approved a few months before we met our patient. We weighed our clinical situation and decided to try to advance this proof of concept molecule into an actual drug. In thinking about that decision process, these are a couple of the key factors that weighed into that decision. This was a compelling medical need. Batten disease, which our patient had been diagnosed with, is a uniformly fatal condition with severe neurologic disability followed then by death. And there were no available treatment options for this condition. Second, this was a single gene disorder and a recessive disorder with both copies of the gene inactivated to cause the disease. And it was feasible that splice restoration of a small amount of gene product could be sufficient to rescue this condition, because we know that carriers that have only 50% gene function are perfectly normal. And third, we considered the fact that this was actually in our favor. This was a unique mutation found in a single patient, not a drug that we would be able to trial in dozens or hundreds or thousands or tens of thousands of individuals. What that had decided disadvantages in terms of being unable to engage any companies to advance this molecule. But on the other hand, it also gave our project a different flavor, one of more an individually consentable intervention as opposed to a broadly marketed drug with public health implications. And this work, this internal assessment was then supported by ex-FDA regulatory consultants, as well as direct consultation with the FDA when we proposed our thinking and our scheme to the FDA Division of Gastroenterology and Inborn Errors, supported by consultants Lauren Black, Mary Pendergast, and Sarah Goldkind, all of whom had FDA experience. We were able to get their agreement that we should be able to move quickly in cases like this and to develop approaches that didn't have a precedent at the time, but we could develop accelerated approaches to manufacturing, drug release testing, formulation, and animal toxicology that should allow us to proceed. So this project with the FDA's guidance and as well as that of our consultants, as well as fantastic help from industry manufacturers and CROs like Charles River Labs, we were able to put together manufacturing and safety studies under an extremely accelerated timeframe and begin treating our patient within 1 year of the time that we first met her. And this work, now published 4 years ago, has served as a first example of an accelerated approach towards severe, debilitating, and or fatal genetic diseases as a alternate approach, a parallel approach to the traditional methods that we apply towards more larger scale conditions. This work probably wouldn't have received or deserved the attention that it did get if not for the fact that it seemed to show benefit. It actually seemed to help our patient. And the clearest example of that was in looking at seizures, that our patient at the time of our onset of our trial was having 10 to 30 seizures per day. That's shown here in this graph. These are family-reported seizures. We also had 24-hour EEGs documenting inpatient procedures, electrographic reported seizures that paralleled these trends. And dose administration, this dose escalation you see in the orange stars going up, was paralleled by a decrease in seizure frequency and a diminishment in seizure intensity that appeared stable over this first year, tracked in this graph. This is what was published in the New England Journal in our initial manuscript. This seizure improvement in intensity and frequency appeared stable over the first 2 years. We did increase the dose at the end of year 2 and saw that the seizure frequency did appear to respond, suppress further, suggesting that, again, evidence of target engagement and beneficial clinical effect. I will say that for completeness, that this was only a partially successful trial because our objective measures for this patient included tracking seizure outcomes as well as quality of life scores that for the family showed marked improvements but those were relatively more subjective. Our other objective measures were looking at brain volumetrics. And sadly, brain volume loss in our patient, which had been ongoing for 3 years prior to our starting this trial, did not completely arrest. It might have slowed, but it did not arrest. And subsequently, in year 3 of the trial, with diminished responsiveness and social interactiveness, our family decided to move her to comfort measures. And she passed February 11th, 2011, a year and 3 years and a week after we initiated the trial in 2018. Her family did grant us the incredibly generous permission to obtain research samples for a postmortem analysis, however. And in unpublished work, this analysis has been incredibly helpful in allowing us to establish that we were seeing a restoration of normal splicing, that our drug was in fact penetrating the central nervous system. And you see here, it's just the levels of normal splicing of the CLN7 gene in her brain, cerebellum, brainstem, and spinal cord arranged from rostral to caudal. And you see a gradient of increased gene target engagement, increased normal splicing that mirrors the expected biodistribution of a spinally delivered drug, illustrating that likely this drug was doing what it was supposed to at the molecular level, but that it was likely administered too late to have a beneficial impact in this patient's condition. So that was, of course, our index case, and it has been published and has also received a lot of media attention. And I wanted to share with folks how the space has grown and expanded in the last several years. And in fact, on the basis of this case and others like it, like Neil's FUS case, like John Watts and his C9orf72 case, there has been significant attention paid in the last few years to this concept that ASOs may serve as a platform for delivering therapeutic interventions, not just for commercially viable indications, but even for ultra-rare indications and potentially even for individual cases as well. And the motivation for this thought is a massive unmet need. It's well recognized that most of the 7,000 genetic diseases are too small for traditional commercial interest. And it's recognized as well that there is not, that this is the system, commercial enterprise is the system upon which societally we rely upon to develop drugs for patients. Yet there is this big blind spot in our system. And so might this be a way to address that blind spot? The scientists among us also recognize that these probes, these efforts, these interventions may also serve critical generalizable scientific value too, that they might allow us to validate critical biology or to probe therapeutic windows, or maybe even to do exploratory studies on potential clinical outcomes to understand and prepare better for larger scale trials. Lastly, the premise of many of the genetically targeted therapeutic modalities that we are working with today, ASOs to start, siRNAs are rapidly catching up, di-siRNAs and other novel chemistries, mRNA therapies and CRISPR therapies, is that these are all platforms with platform potential, that one may be able to keep many of the generalizable approaches to developing these drugs constant, using the same chemistry, the same mechanism, the same administration route, but changing the genetic targeting. and that these types of approaches, expanding our experience with these drugs through these orphan indications, even individualized indications, may allow us to aggregate experiences and develop learnings that will support the platform and make the platforms more efficient. This work and similar work led to the release of the first FDA guidances for individualized medicine in 2021, a series of 4 guidances that pertained here specifically to antisense oligonucleotide drug products, but they contain with them the kernels of the themes that we hope may apply to other modalities as well. And what were some of the concessions or allowances within these guidances as presented now 2 years ago? These guidances allowed for accelerated reviews. They allowed for streamlined submission requirements for investigator-initiated studies. They did stipulate that these types of efforts were at the moment only appropriate for ultra-rare and severely debilitating or life-threatening conditions. But I think that these are clinical parameters that this community knows very, very well. And just to shout out to my colleagues, Neil Schneider, Bob Brown, John Watts, that this first wave of individualized therapies with efforts in Batten disease, FUS ALS, and C9orf72 ALS, as you've heard about, were really the linchpins for these early efforts. So at Boston Children's Hospital, I'll give you a snapshot into current vignettes and current activity in the space. In the 5 years since we first met our patient, this field has really grown a lot. And there are now dozens of efforts like this underway. Within our own institution, these are the efforts that we've been involved in. An effort for CLN7 Batten disease is described. I'll have time to tell you about ataxia-telangiectasia because I think it illustrates some of the themes that are emerging in this early infantile space. I don't have time to tell you in detail about our efforts for KCNT1 neonatal epilepsy, a severe infantile seizure syndrome, or FLVCR1 retinitis pigmentosa. That's an interesting inherited progressive blindness genetic condition that we are treating in a young child in Colorado with intravitreal injections. But happy to discuss any of those on the panel. I do have some time to illustrate this AT case, which was inspired by meeting an infant who was diagnosed with a fatal genetic disorder, interestingly enough, actually at birth. This is a young child who underwent the standard newborn screening paradigm that is designed to look for treatable conditions. Hers was actually flagged for an abnormality that could signify severe combined immunodeficiency, SCID. She had a low T-cell receptor excision circle count. Further workup, however, revealed that she did not have SCID. She did not have a SCID immunodeficiency requiring gene therapy or transplant. But unfortunately, she did have another condition, one that newborn screening was not supposed to look for, a condition called ataxia-telangiectasia. And the reason that you're not supposed to look for this condition is that it's currently untreatable. It's largely asymptomatic at birth. So her families then are now told of a condition which will not manifest in serious form for a few years and for which you can't do a whole lot about. This is a progressive cerebellar neurodegenerative condition. These children begin, they do have mild ataxia at birth, but really serious symptoms and serious divergence from the normal typical neurodevelopment becomes most evident by age 3, 4, 5. By age 10, these children are wheelchair requiring and they are unable to communicate, unable to swallow, and they have numerous medical complications from those incoordination deficits. And it's typically fatal by young adulthood. There are no, unfortunately, disease course altering treatments for this condition. And it's caused by mutations in a gene that is called the ATM kinase. It's a critical mediator of the DNA damage response. In fact, it's the DNA damage response that leads to you having abnormal T-cell receptor excision circles, but that's another story. And that is the molecular basis for this condition. Specifically, however, for this patient, one of her mutations in ATM was an unusual mutation, one that created a new splice site, just as the original Nielsen mutation created a new splice site. And so compressing 18 months of work into a single slide, we were able to recognize that unusual genetic mechanism of action. This was and design drugs to combat it. So she had a C to T change in the middle of exon 53. They created a new splice donor site. We blocked the use of that splice donor site with a series of antisense oligonucleotides and used those to demonstrate in patient cells RNA rescue as well as functional restoration of the DNA damage response. And with supportive data entirely from in vitro studies like that, we were able to advance this as a sufficient proof of concept to the FDA, such that when coupled with appropriate in vivo safety studies in rodents, allowed them to grant us permission to initiate an investigational trial for this patient when she was age 2. That was initiated in January 2020. It's now November 2023, nearly 4 years in. And we continue to hold our breath and watch our patient carefully, but she's doing extremely well. We are looking at measures of ataxia in our patient that suggest that she's doing in the upper percentiles of children with ataxia telangiectasia. Now, unfortunately, there are not a lot of detailed neurologic histories available for young children at this age because most patients with AT are actually diagnosed much later than this. And so the ability to accidentally pick up these cases is actually a very recent one in the last 7 or 8 years because of the advent of changes in newborn screening technology. But by a variety of clinical measures, as well as biometrics like this peak limb velocity metric that's being advanced by our colleague Anupam Gupta, she's doing really quite well. We are following serial imaging to look at brain volumetrics. Here are example images from a manuscript in preparation. These are images generously shared with us by a colleague in the UK, Rob Deneen. And the natural history of untreated AT is to demonstrate significant cerebellar folia thinning by ages 5, 6, and 7. And our patient does have some thinning, but arguably it appears to be progressing more slowly than the typical course. Now, we're not, again, ready to declare victory. I think that this is a long latency condition and more time will be necessary to know whether this was actually working. But so far, things are looking promising. Now, this project gives me an opportunity to talk about the landscape of these types of opportunities. So far, I've described to you mutation-specific therapies. And a critical question that folks need to ask is how many patients like this are there? Are these unicorns that only happen once in a million? Or do they happen more often than that? And is there a way to systematically identify them? Our partnership with the AT community allowed us to answer this question because the AT Children's Project, a nonprofit foundation started by a coalition of AT families, led by Brad Margus, and with support from the Broad Institute, from Anthony Philippakis and the Data Sciences Platform, they created an international registry of patients with AT. And they collected phenotypic and genotypic information and performed whole genome sequencing in hundreds of kids with AT that had been clinically ascertained with gold standard clinical diagnostic criteria. And we took the opportunity for the existence of this registry in the data set to develop a taxonomy for all the types of genetic variation that we analyzed could be amenable to correction via a splice modulating ASO approach. And we used the fact that this was again, there was comprehensive genetic data available for these individuals. We could make sure not to miss any diagnoses. We could do analyses not just for point mutations, but copy number variants, structural variants, mobile DNA elements like the unusual retro element insertion that occurred in our index Nielsen patient, repeats, et cetera, et cetera. And then we could use a variety of sophisticated algorithms to predict splicing impact, and then experimentally validate these using either mini genes or patient cell lines. And the upshot of our report, which just came out in the summer in Nature in July 2023, was that 70% of the, I'm missing a slide, 15% of the individuals within this cohort had variants that were amenable to this type of ASO splice modulating approach. And if you looked in particular to understand what types of mutations were the ones that were amenable, it turned out that 70% of these treatable variants were deep intronic variants, hiding between the exons, not typically captured by clinical sequencing these days because most people aren't doing whole genome sequencing. But these variants shown circled in green are the deep intronic variants. The red ones are the ones that are amenable to splice switching. There are other exonic variants that are sometimes amenable to splice switching. There are some other variants in the donor or receptor regions, but the majority of them lay within this deep intronic region, illustrating that a whole genome sequencing actually is the way to find these types of variants. Another important feature of the data set was the following slide. This is a histogram showing the number of unique variants that we encountered and how often they recurred within the individuals in the cohort. And of the 36 individuals within these 235 that we studied, this is the distribution. There were 13 patients with a single recurrent mutation, a deep intronic mutation shown on the far right. This parenthetically is a previously known ATM mutation that is the cause of nearly 20% of AT cases in the UK. There were 5 patients with a synonymous mutation that created a new splice site. There were 2 patients with 2 closely related mutations that created new splice sites. And then there were 14 patients that had individual private variants. And if you run the numbers, it turned out that one ASO treating the most recurrent variant could be used to treat a third of the cohort. 4 ASOs could cover over half of the cohort. But treating the entire cohort would require one to develop 15 ASOs. So this illustrates on one hand both the opportunities but also the challenges here for this type of work, that this is going to take a lot of drugs. We're going to have to get much more efficient at the design of these drugs to scale to the full potential. Coming back from those observations to our index trial, the drug that we deployed for our index patient, we named it Adapexin. Corresponding with what we found from that genomic analysis, it turned out that when we launched this trial, there was only 1 patient in the world that we knew of with AT and this mutation. But it turned out that we soon identified, a year after initiating the trial, we identified a second child in Europe with AT who also had that same mutation. And we managed to enroll him in an experimental protocol and started the treatment in Boston. And we were able to return them to the excellent care of our collaborators at the University of Tübingen, where he continues to be treated there under an individual patient, a named patient program in Europe. We think is the first patient in Europe to be treated under this paradigm there. And we've also reached out to collaborators in Turkey. It turns out that this mutation is actually endemic in Turkey. And there have been 5 additional cases in Turkey there too. And we are working with neurologists and regulators there to try to advance this trial and open it up as well. So I think mirroring the excellent work that Neil did with Jaysafusen, I think that a reminder that N of 1s is a handy handle for discussing this type of work, but it's not really N of 1s, that these are cases that have, these are efforts that have the potential to expand significantly. So I'll close here with just a couple of comments that, as I mentioned, these are 5 cases that we've advanced at Boston Children's, and it's very early days. There are promising cases. There are cases that show both promise and have had some failures associated with them too. Our KCNT1 neonatal epilepsy trial was, on one hand, we were excited to see remarkable seizure reduction in this epilepsy targeting as a result of this epilepsy targeting ASO. However, we were also saddened that our ASO drug induced hydrocephalus in 2 patients, and one of those patients' families decided to withdraw care. So this is not an easy field to work in. But there are many other parties that are advancing this type of work. And between the FDA's leaning in with their guidances, the Oligotherapeutic Society, which wrote several white papers on the subject, NINDS, which is creating a mechanism for advancing these types of efforts through the URGENT program. Our colleagues at Columbia, at the UMass, University of Massachusetts, in the Netherlands, there's been created a Dutch Center for RNA Therapeutics that is working on ENS1s. And Ionis Pharmaceuticals has created a foundation called NLORM to support the development of these types of drugs for ultra-rare indications. I'll shout out in particular to them for their first case that was covered in an article in the New York Times, an ASO for another untreatable disorder, KIF1A associated neurologic disorder. Stan Crook, Frank Bennett, and their team at NLORM advanced a drug that was administered under Wendy Chung's watchful care for a patient with KIF1A. Wendy, who's now at Boston Children's, is seeing remarkable early returns for that patient. So looking ahead, some discussion items and provocative thoughts that we might pursue in the panel. There's many questions here that remain to be addressed in this parallel path. We have a lot to learn from the traditional path for the good work happening in the ALS field, but here with very small n's, how do we extract signal from these trials to establish whether these interventions work, or are we going to always be criticizable for being in the realm of anecdote? What aspects of these diseases are we going to discover can be stabilized or possibly even improved within what therapeutic windows? What are the generalizable disease learnings that might come from these studies? Can this type of development be made more efficient? Right now, there have been sufficient resources and interest to do this for a dozen individuals, but is this, how would this scale to hundreds or thousands or tens of thousands? And how do we balance critical questions of urgency and timeliness together with risk? From a regulatory and ethics perspective, there are questions about whether this constitutes compassionate care or research, whether these are clinical trials or somehow whether they're medically innovative care. There are critical questions about what would appropriate standards be if the FDA were to weigh in about approval or to allow reimbursement. And what are the modes of sustainability of this? Might companies be involved? Is this in the realm of nonprofits? Is this in the realm of medical procedural care? Under any of those models, how would one ensure equitable access if this truly is shown to work? I'll end by saying that if any of those questions intrigue you, I encourage and invite folks to participate in the N1 Collaborative, nonprofit that we started that's hosts seminar series addressing these topics, trying to refine the discussions into best practices, trying to encourage data sharing into this early field, and democratize access, and our website is shown here. Thank you so much, and look forward to the discussion with my panelists.
Thank you. This was incredible. I had to say, providing hope to these families, I'm sure is an incredible experience. So thank you for your work and leading this field.